Good afternoon. Welcome to this exciting symposium on the mitral valve as part of Cardiovascular Innovations. I'm lucky to be chairing the session with Viren Turani, who, as many of you know, is a renowned surgeon in the field of structural heart. And together we have a really exciting panel with some fantastic speakers and titles. I don't want to waste any time. It's late for some of you, so we're going to get right into it. And I'm going to introduce our first speaker, Gagan Singh, who's going to be telling us about maybe who are the best patients with functional mitral regurgitation for transcatheter repair. Gagan, it's all yours.
Hello, my name is Gagan Singh, and I've been asked to discuss the type of patients that would be kind of the most beneficial, or that would derive the greatest benefit from transcatheter repair. Here are my formal disclosures, and I think before you discuss the type of patients that would benefit, I think we have to talk about functional MR in and of itself, and I think as a community, we're learning more and more about MR as not being just primary and secondary MR. In other words, degenerative or functional, but even within functional, even within secondary MR, we're learning that that there's differences. There's patients with primarily non-ischemic or ischemic, and now there's also this phenomenon of atrial functional MR, and perhaps more on that later in a separate talk. But for the purposes of this discussion, in terms of who we think is going to be beneficial, or who's going to benefit from this type of therapy, the question becomes, do we have high level data for patients who would benefit? And the answer is yes, we do. We have high level data which suggests that both patients with non-ischemic and ischemic MR with certain anatomic and clinical conditions would derive benefit. But we also have data, high level data, which suggests that there are, in the same group of patients, non-ischemic and ischemic MR that actually don't benefit. And Paul Grayburn really beautifully, I think, outlined this in his manuscript a few years ago now, where patients who do benefit are labeled as proportionate MR, and we'll get into that a little bit later on, and versus this group of patients who don't benefit are termed as disproportionate MR. In other words, their LV dysfunction or their MR is disproportionate to the degree of LV dysfunction, and so they may not benefit. Now, there probably are other MR categories as well, and there's this higher risk group of MR patients that may not necessarily fit into either of these clean-cut descriptions, and I again may briefly touch upon that, and whether there is a role for transcatheter therapy in those patients, and then obviously atrial functional MR patients. We have some retrospective data that hopefully will be coming out soon that kind of talks about this group as well. So I thought we'd kind of, with that introduction, let's talk a little bit about a case, a relatively quick case, and just to kind of lead off the symposium here. But here is a 70-year-old female. She's actually referred to us for transcatheter repair, and she's been having progressive heart failure symptoms, class 3 heart failure symptoms. She's a diabetic, high blood pressure, severe mitral insufficiency. Now, her outpatient cardiologist had done a pretty remarkable job of getting her hemodynamics under control. As you can see here, he had her on Entresto, Carvedilol, Bumex, and Aldactone. She had a non-ischemic cardiomyopathy, which was, in terms of the etiology, was unclear. She had undergone cardiac MR amongst other evaluations to search for a reversible etiology, but couldn't really find it. And so she settled at an EF of 35% with a biventricular ICD, and again with a persistent cardiomyopathy, MR, and symptoms. And so she ultimately was referred to us. So here's her transthoracic echo when I saw her, and you can see that she does have a cardiomyopathy. It's kind of global kind of LV dysfunction. She's got an ejection fraction of about 35%. Now, these numbers are going to be important, especially when you talk about who's appropriate, who's not appropriate. I think we need to, as a community, move on beyond just the presence or absence of functional MR, but more importantly, presence or absence of functional MR. However, what is the patient's ejection fraction? What are the patient's left ventricular dimensions? Whether you use a end diastolic dimension or a end diastolic volume, these are going to be important numbers. And she did have some pulmonary hypertension, but at the time of right heart cath, a lot of this was related to left-sided disease. And so, one of the things that we immediately picked up on was that her mitral gradient was 5, and whether mitral transcatheter repair would be prohibitive in her. However, notice there's not a lot of calcium in the leaflets. The leaflets are mobile, and I think likely a lot of the gradient is flow related and could be, and she could have room for at least one clip and to help improve her outcome. So we finally did bring her in for a mitral clip procedure. This was a relatively recent case. So here, after the clip is inserted, I'm not going to take you through the whole case step by step, but after the clip is inserted, we kind of align the clip and establish our trajectory. Ultimately, the clip is advanced below the leaflets, and here is a prototypical grasp, which, again, I wish every grasp was this crisp, where you have a nice view of the shaft, both the arms, both the leaflets, and then ultimately the grippers come down. And then here, after we've grasped, we do a quick 3D alignment just to make sure that our clip is perpendicular to the line of coaptation, and it's kind of exactly where we wanted it to be, and we are right at the center at A2P2, and we've achieved a successful grasp, and we go ahead and tighten, and after we fully tighten, you can see here there's a clip in the middle. She had a gradient of 4. Her MR was actually reduced quite a bit from severe to mild, and we certainly had an acute procedural success. And this is now her at 30 days. 30 days, her functional status has improved quite a bit. She nearly, had a 35% improvement in her 6-minute walk test. And you can see here that with the clip in place, ejection fraction, actually, if anything, the LV cavity may look a little bit smaller. I really like the short axis parasternal view, which kind of gives you a global view of the entire coaptation plane, and really, in terms of the jet origination or the PISA of the residual MR, is very minimal. These are essentially low volume, high velocity jets, and the patient essentially ended up with mild MR. And here's a 3D en face from transesophageal echo, and she's left with a nice double orifice valve. So this is clearly a patient who benefited from the therapy, who benefited from treatment, and so she really is an ideal patient. And I think when we start thinking about ideal patients, and you screen these patients, you have to start thinking along the lines of not only just proportionate, disproportionate MR, but I think, is this a mitra FR, is this a coap patient? And so, I'm not going to do an exhaustive dive into each of these studies, and that's been done multiple times over and in multiple manuscripts. But I wanted to highlight just a few things. And that if you look at on this table on the left, which is looking at inclusion criteria, and if you look at mitra FR versus coap, and again, this has been debated, the patients in coap had ejection fractions that were slightly, in terms of inclusion criteria, they allowed for EFs of greater than or equal to 20%. That's probably not as important as this EROA in terms of looking at the objective assessment of mitral regurgitation severity. These patients in coap certainly had greater greater MR degree. Now, we'll talk about the dimensions. There wasn't a specific cutoff in terms of inclusion-exclusion criteria, but when you actually look at who was enrolled in the trial, there was a couple of things that are interesting. Now, if you look at the breakdown of the EROAs, patients in mitra FR, again, 85% of them had either an EROA, the vast majority of them had EROA of 0.2 to 0.29. And then 85% of them had less than 0.4. On the other hand, if you look at coap, a lot more of them had EROAs, about 40% of them had EROAs greater than 0.4, and again, another 46% had EROAs greater than 0.3. So in other words, the distribution of severity was greater, or the distribution of patients having severe MR was greater in patients in coap. Now, this LV end diastolic volume, or the indexed end diastolic volume, is also an important consideration. In coap, if you looked at just the dimension alone, it was, I believe, in the low 6s, 6.2, 6.3, but the index volume was about 100 compared to 130 in patients with mitra FR, and the ejection fractions overall were about the same. So I think in the case example that I showed you, and kind of what we learned from these two trials, the best way to really sum up who these best patients really are for TMVR. And again, you can put a clip on any valve, you really can, whether it's a mitra FR, whether it's somebody a little bit better than mitra FR, or somebody a little bit worse than coap, or sorry, the other way around, somebody worse than mitra FR, or somebody better than coap. You can obviously put a clip on everybody, but the question is, who are who's going to derive the greatest clinical benefit. And I think this is an important or a really nice way to look at it. I can't take credit for this diagram, and really, I think this kind of tries to simplify in a way that Paul Grayburn did, where when you talked about proportionate, disproportionate MR, but really you want to think about the patient's LV systolic dysfunction and the severity of the LV systolic dysfunction. The one thing that's not in this table or this diagram is LV dimensions. They talk about LV and systolic dimension here, but I probably probably would do a deeper dive into looking at the LV end diastolic volumes or the end diastolic dimensions more so. But regardless, in patients who have severe LV systolic dysfunction versus mild to moderate LV systolic dysfunction, and again looking at the severity of the MR. And what we know is that if you have severe LV systolic dysfunction and only mild to moderate MR, in other words, your EROA is less than 0.3, we know the mitral clip is not going to work in that subgroup of patients because this is truly a ventricular problem. On the other hand, you have a group of patients that have, again, mild to moderate MR, and they have mild to moderate LV systolic dysfunction. And really, if they're having symptoms, it's probably the MR is not causing them problems. And really, it's more escalation of medical therapy. And if they are really having symptoms, it's perhaps a ventricular problem. And there are now other transcatheter-based therapies that are looking for LV remodeling, and I don't even know if remodeling is the right word. I would call it mechanical remodeling of the LV, and then perhaps that this might be more beneficial for this group of patients, but at least not transcatheter mitral repair. Now there's this higher risk group of patients that have very severe LV dysfunction, more severe MR, and again, there's a gradation even within here. There's going to be a group of patients in here that are probably more MITRA-FR-like, and then there's a group of patients in here that are probably going to be more COAPT-like. And we still, as a community, haven't been able to tease that out. And I would, pose or I would, promote a trial looking at this group of patients and teasing out, who would benefit from here. It would be a difficult trial to do, but I think it is certainly doable. And then finally, so to answer the question, which is that group of patients that really does benefit from transcatheter repair and FMR? Again, it can be ischemic or non-ischemic cardiomyopathy, but again, importantly, understand that they need to have proportionate mitral regurgitation. In other words, they have moderate to severe MR, but they have only mild to moderate LV systolic dysfunction. In other words, their degree of MR is far greater than what would be expected given their LV systolic dysfunction. So thank you very much.
Gagan, great. Thank you so much for the great presentation. And I think it raises a lot of discussion and a lot of questions. I want to remind the participants, we do have a chat function. So if there are questions you'd like us to answer, to please submit it to the chat function. I'm probably going to ask you maybe just one question, one or two questions, and then we'll move on. But I also we have a great panel who's here. So if any of you would like to answer a question, maybe just raise your hand and I'll bring you in. So, we've talked a lot, and every presentation now talks about the differences between MITRA-FR and COAPT and the whole proportionate, disproportionate. One of my concerns is when we do this is, and I think you sort of highlighted in that last slide, when you divided it into 4 groups, is there is a group of patients that, maybe in the MITRA-FR that probably do benefit, even though they have large LVs. If they have very severe MR, they probably do benefit. And maybe how they benefit is different to the COAPT patients. So it may not be benefit for mortality, but it may be benefit for symptoms and hospitalization. And the reason I say this is, I worked in Europe for many years, and 2/3 of the patients we treated were functional MR, and majority actually were, more the dilated LVs and the more really advanced patients. Any thoughts, Kagan?
No, absolutely. Azim, I totally agree. I think there's a subset within MITRA-FR that probably do clinically benefit from mitral clip therapy. Then there's a subset in COAPT also that don't benefit from mitral clip therapy. And I think it's our job anatomically and clinically to tease those patients out. There is even a higher risk category of patients that probably wouldn't fit exactly in COAPT that may benefit as well. And I think that's where we need to continue to push and identify both anatomic and clinical criteria for those patients.
Vina?
Yeah, question for you, Gang. That was a great presentation. Thank you. When do you start thinking about when are you going to do a mitral valve replacement on these patients versus a mitral clip? So are all patients that come in for FMR evaluated for both, especially when you have a pre-grade in 5? And I understand, and I agree with you that a lot of that was from the jet. Do you look at both and say, this one I'm going to take into mitral valve transcatheter mitral valve replacement, this one I'm going to do a clip on? Because at this point, once you've done a clip and you kind of split the jet a little bit, and is that patient, if that patient is young, let's say 60, 65, that may become problematic later. If the patient's in their 80s, maybe it's not problematic. So just tell the audience a little bit, how do you decide on which pathway you're going to take somebody for a clip versus a replacement?
Yeah, absolutely. I think
catheter replacement, not a surgical,
right.
Catheter replacement.
Yeah, absolutely. Now we're fortunate because we are a Tendyne site, and we've had access to Summit, and part of the Summit protocol, especially is looking at this patients who you believe that you cannot, and we have Paul on the call here as well, so he can correct me if I'm wrong. But if we have patients where you do not believe, if they have secondary pathology and you do not believe that you can reduce their MR to some satisfactory degree, whether it's due to some sort of anatomic limitation, high gradients, calcium, calcified subvalvular structure, and so on, then those patients would get randomized to a clip versus transcatheter mitral valve replacement. We still, to this day, don't have definitive data that transcatheter mitral valve replacement is indeed superior or non-inferior to mitral clip therapy. Currently, the standard of care now has become transcatheter mitral valve repair with mitral clip. Replacement, I think, is certainly attractive, especially in patients where you cannot decrease their MR to 1 or less, and patients who basically have prohibitive anatomy. So I think only time will tell with Summit, but I think having access to the trials and patients who you do not believe you can truly achieve a substantial MR reduction, those would be the ones that I would consider for mitral valve replacement.
Yeah, I agree. Both Paul and I are on the leadership of the Summit, and this would be, I think this would have been actually a good patient that might have fit into a Summit type of protocol. What do you think about it, Paul?
Yeah, I mean, I think it's hard, because, with TMVR, you get no MR. All the MR is gone. But with mitral clip or transcatheter repair, you get an overnight stay and you're home the next day. So,
right.
So it's really, really hard. So and the time will tell with the Summit trial, with the randomization and comparison between the two arms as to which strategy might be better. Personally, I think they're going to complement each other.
Yeah.
And it remains to be seen.
Yeah.
So Vino, maybe you're the one surgeon here, so let me pick on you a little bit.
Yeah, of course. I'm used to it. Go ahead.
After the COAB data, is there still an indication for isolated mitral valve surgery in functional MR?
I don't see as much FMR patients. I used to do a lot of FMR patients surgically before, especially during the era when we were doing the NIH Cardiac Surgery Network trial for IMR, we were doing a lot more. I see a lot less now. The main places where surgeons are attacking FMR patients is when there's a concomitant procedure on top of that. For instance, their patient needs a coronary bypass that's not PCIable, and by the way, they have an EF of 30-35%, and they have severe MR. They have severe AS, and they have severe FMR. That's not great for a TAVR clip type of procedure. So we're seeing a lot less FMR surgically unless they need something else. And that data, we looked at the STS database, and there's that we're seeing that number go down dramatically. My guess is as TMV repair has become mainstay, and then TMV replacement is also starting to make some headway.
Mm-hmm. Maybe we should go on to the next speaker, Vina. Why don't you introduce our next talker?
Absolutely. So our next speaker is going to be Ashish Prasad from Banner Health in Phoenix, and he's going to talk about device selection for transcatheter repair in degenerative and functional mitral regurgitation. Ashish?
Good afternoon. My name is Ashish Prasad, and welcome to CVI Digital 2020. I practice at Banner University Medical Center, and I'm in 10 minutes going to describe some device selection options for transcatheter mitral valve repair. in both degenerative and functional mitral regurgitation. I do not have any financial disclosures. So before we get into the presentation, I'd like to present the big picture. The big picture is that this field is rapidly evolving, even though currently we just have the MitraClip as the only FDA-approved device available in the United States. There will be another edge-to-edge device called Pascal. There are several annuloplasty direct and indirect devices that were in clinical trials that unfortunately have been put on hold temporarily for now, which we'll talk about a little bit. And of course, the whole field of neocords is also rapidly evolving. We'll talk about one of those transseptal platforms as well in this presentation. The other big challenge with mitral regurgitation is that it's hard to quantify MR because it depends on loading conditions like the blood pressure, et cetera. Even in a study like the post-market evaluation of the Gen 4 version of the clip, there were almost 30% of cases in which the core lab adjudicated MR as being moderate, even though the site adjudicated MR was felt to be severe. The registry I'm referring to is called the EXPAND registry. So it's a challenge in actually quantifying the severity of MR. The third point I'd like to make relates to the fact that we typically want to quantify and classify MR as DMR or FMR or primary or secondary MR, but I think that is a very limited or short-sighted approach because not all DMR is the same and varies from bileaflet prolapse in a Barlow's patient to an isolated P2 prolapse. And similarly, not all FMR is the same. You have FMR that could be related to annular dilatation from what's so-called type 1 or atrial FMR versus ventricular FMR related to either ischemic MR or ventricular remodeling in the setting of LV dysfunction. Regardless, treatment goals vary depending on the type of MR we're treating. For example, a patient with primary MR or DMR who has low or intermediate or even high surgical risk, the tolerance for residual MR is almost low to none. On the other hand, patients with FMR can often be left with mild to moderate MR, as was seen in the COAPT study with little to no long-term or intermediate-term hemodynamic consequence. And in addition, the patient's age and comorbidities, apart from left atrial pressure, dictates their functional class improvement after the recovery of from treatment for DMR and FMR. And hence, not all treatment goals for every type of MR is the same, and abolishing color is only one aspect of an endpoint for patient treatment. The last point I'd like to make is that unlike when mitral valve repair is performed in the traditional way, where you'd like to achieve everything that you can while you have the heart open and in a flaccid state, transcatheter treatment can often be seen as treatment that can be performed in stages. And by that I mean the least invasive procedure can often be started as the first line of treatment with, as long as preservation of future treatment options persist, then subsequent treatments like annuloplasty followed by an edge-to-edge repair down the road, or even a annuloplasty followed by a transcatheter mitral valve replacement are all potential options that we can offer patients, not in the same setting, but over their lifetime. So in the device landscape, there are the edge-to-edge repair category, in which you have G4 MitraClip and Pascal. You have indirect annuloplasty through the coronary sinus with the Carrillon device that I will touch upon, direct annuloplasty with the Cardioband, which we'll talk about, as well as some transeptal neocordial implantation with the pipeline device, which I'll also be touching upon. This is data from the STS Adult Surgery Database from 2018 that looked at annuloplasty and leaflet resection as being the predominant strategies of how surgeons approach mitral valve repair when done open. Occasionally artificial cords, and very rarely an edge-to-edge repair is performed. But often annuloplasty plus a leaflet resection strategy is the predominant strategy of repair. Degenerate MR, as we all know, is a leaflet problem. And whether it's from type 2, which is excessive leaflet motion, or type 3, where you have limited leaflet mobility, or normal leaflet mobility as in type 1, the therapeutic target for degenerative MR is the leaflet and the cords, often combined with annuloplasty to overcome adverse LV remodeling from LV wall stress once the leaflets and the cords are repaired. We'll talk about some non-ideal edge-to-edge cases. Almost 20% of cases are felt to be non-ideal MitraClip cases. And those can be from the following 5 reasons. The primary jet could be outside A2P2. It could be multiple jets, wide jets. The mitral valve area might be small. The leaflets could be severely degenerate with wide flail gaps, or might even be, frankly, like a Barlow's valve. Or there might be calcification in the grasping zone, all of which makes this an extremely challenging case. Regardless, we'll talk about 2 such scenarios that I came across last month, and we'll present those to you. This was a patient that had a screening echo assessment demonstrating a wide jet of central mitral regurgitation and a commissure to commissure gap consistent with a restricted posterior leaflet. Also notable is some calcification in the submitral apparatus in the medial commissure. This is clearly not an ideal case for mitral edge-to-edge repair with the clip. We, however, attempted to do this in the absence of any other options available for this patient. We ended up putting 3 NTR clips starting from medial to lateral. The residual gradient was 4. And as you can see on the left panel, the mitral valve orifice clearly does not look normal. In fact, it's quite ugly. And surprisingly, there was adequate orifice area in the 2 spaces in the commissures, both on the medial and lateral side. Another example of a case that's non-ideal is a patient that has a limited or a small mitral valve area. This patient had large central jet of mitral regurgitation. The LV was small. She had previous radiation. It was a patient with end-stage renal disease. Her mitral valve area was estimated to be 3.5 centimeters squared, which is clearly below the IFU of 4 for a mitral clip. Our mean gradient was 3, and hence we felt that we could at least attempt to try to do this case. In doing so, we felt that we would be using a single clip. An NTR was chosen, and at any point during the case, we tried using the NTR at different points in the A2P2 zone, but at each time, even with decreasing the tension of the clip, the minimum gradient that we ended up with was 7, and at some point we had gradients as high as 10 or 12. We obviously couldn't leave this behind, and so we took the clip out and continued to offer the patient medical therapy at this point. So in 2020, what are the clip options? Well, there are 4 clips out there. XTW, NTW are the 2 new kids on the block. These are the wider clips with independent grasping options, as well as a 50% extra area of grasp. Typically, the XTW, I think, has its role in degenerative MR cases with a wide jet and an adequate mitral valve area and good leaflet length. I think the XTR and the NTR are probably going to be relegated as secondary clips, with the NTW being the favored clip in functional MR when the leaflet length is less than 9 and the jet is wide. These are, again, just guidelines. We fully don't know how the clips will be used once they're widely released, but these are some of the pros and cons of the wide clip versus the currently available technologies. Moving on, the transseptal pipeline procedure is a very interesting transseptal procedure in which neocords are implanted with a transcatheter approach. The first part of the procedure is very similar to a mitral clip involving a transseptal puncture with a delivery sheet that resembles the CDS. And it starts with traversing the zone of interest in the mitral valve and then firing a ventricular anchor in between the papillary muscles and followed by attaching a leaflet anchor and then adjusting and locking sutures once this is anchored in place and then left in place once fully deployed. The first in man case was performed in Colombia by Jason Rogers. And as you can see, this was the images when presented at TCT last year. The case was done a few weeks prior to that in the fall of 2019. As you can see, there was a predominant P2 prolapse here, which was treated with 2 cords implanted. Result looks spectacular acutely. Unfortunately, the anchor in the LV, for some reason, got loose and the patient developed recurrent MR and was treated with surgery electively a few days later. However, what this really proved was this first in man study was a proof of concept that transfemoral transseptal chordal replacement is feasible. It restores mitral anatomy, mitral geometry, recreates a neopapillary muscle tower, allows us to have a normal chord angle and chord length in a non-flaccid heart, and does not cause mitral stenosis and preserves all future options. So technology that's highly favorable for this therapy and actually is being worked on since W.L. Gore has taken over Pipeline and purchased it. I've had the privilege of working on some newer designs of anchors in my backyard up in Phoenix, where the Gore headquarters are. And I think that hopefully by the end of this year, we'll be back in South America for some more human implants with a modified version of the LV anchor. The next device I'd like to touch on is the Cardioband direct annuloplasty system. It causes direct reduction of the annulus similar to what's done in surgery. It's a transseptal procedure. It's more involved, causes annular reduction, and can be adjusted in a non-flaccid heart, and then real-time confirmation of results allows adjustment and release once the MR reduction is felt to be satisfactory. Clinical trials are currently on hold, but this is a case that I borrowed from Brian Wisenhunt, in which he demonstrates very elegantly a case of atrial MR here, which was the first case treated in Salt Lake in 2017. Dramatic results, MR reduction that remained favorable up to 2 years, with improvement in forward stroke volume as well as in LV and diastolic and systolic indices. Once again, this is a very exciting technology, which I'm sure will have a role to play in the future. Indirect annuloplasty is another approach to the coronary sinus. Again, this is a very safe procedure done through jugular approach with a 9-French system with devices fully recapturable and retrievable prior to its release. It has proximal and distal anchors that are connected by a shaping ribbon. The heart's venous anatomy is used to sense the mitral apparatus. I think the recent data from Europe suggests that having a pre-procedural CT can predict which patients might be favorably impacted with this therapy. This is a case done a few years ago. Again, a functional case with a lot of MR, low ejection fraction, huge left atrium. Picture on the left is followed by the image on the right, which shows the device being used to measure the length of the sinus with an angiogram. A concurrent coronary angiogram is performed as well to ensure that there's no kink in the circumflex artery, which happens to exist in a similar zip code as the coronary sinus, and is one of the complications that can occur from this procedure. But regardless, in the favorable patient, there's quite a marked improvement in the mitral regurgitation, although not as dramatic as with edge-to-edge and/or direct annuloplasty, as shown on the right panel. In conclusions, I want to say that decision-making for mitral valve repair options are complex and do need to be individualized. Currently, the landscape is limited with edge-to-edge repair with Pascal coming soon, but currently only possible with the MitraClip. In the next few years, I wouldn't bet against these newer technologies that are looking exciting and promising. Combination therapies will probably be used and will need to be tested rigorously in randomized studies. And I think the mitral space lends itself to a concept of center of excellence because of how complicated and complex these patients are, as well as how diverse the pathology is. And ultimately, a well-functioning collaborative heart team decision-making will be crucial in providing patients the best care they need. Thank you for your time and attention.
Ashish, that was a great overall presentation. I mean, I really learned a lot, and you really covered a lot of products over the time frame. So I think that was just excellent. Congratulations on this great presentation. So I think that what obviously we're all a little behind in mitral technology compared to TAVR, right? I mean, we've now just getting into the middle of these trials. When you look at this, there's Pascal currently coming on. Neocord for transapical repair is up and running. Harpoon is up and running, which will be starting soon. You mentioned Pipeline, which is now Gore. Transeptal, I think, will be coming in Q4 2020, and it'll be really upping. It'll ramp up in 2021 for enrollment. And so I think we have a lot of new stuff coming on board. One thing you said to me, I think that caught me, and I wanted to get your thoughts on this. What do you think will end up being easier? Because in surgeons, we do piecemeal it. We start with the one thing, then we add a second, then we add a third, we add a fourth to make the mitral valve work. Do you think it's going to be the clip that becomes the first, and then you go to an annuloplasty? Or do you think it's going to be the neocord? Because in a neocord, if you do a clip, it's going to be hard to do a mitral valve replacement down the road transcatheter-wise, right? It's going to be very difficult to do a transeptal evoke, or it'll be tough to do a transeptal intrepid down the road, unless you try to do electrocautery to take the clip off, like the Alaska procedure. Is it going to be neocord that you think is going to be first transeptal, followed by an annuloplasty, or you think clip will remain the main standard of care?
That's a great question, Vinu, and I think I'm going to defer to some of the surgical data that I get from talking to you all on a day-to-day basis while interacting. That it's pretty hard, when our cases that do have had a clip end up going to surgery, either for a VAD or when they have to have surgery for whatever reason. It's not so simple to take the clip out, and the thinking is that I think the technology that will give you the most options and leave most options open, I think will be the first option. In that respect, I think clip clearly is not that. So, I mean, whether it's neocord for degenerative cases and annuloplasty in functional cases, that's, I think, a question that still needs to be answered. But I think conclusively, I don't think clip is going to be the go-to first option once we have other therapies.
5 years from now, right? It is now. Anybody else have any comments or questions?
Yeah, Vino. So when you guys do surgery, is there a time when you would ever do cords without putting a ring on? Ever?
No.
Right.
It's inconceivable that we would do that. In fact,
exactly.
We actually put the stitches in the annulus first, and that brings the valve to us. And then after we test it, then we say, okay, you're going to be a cord, you're going to be a resection, you're going to be a commissuroplasty. We actually put the stitches in first most of the time.
Right. So I don't think that we should even try doing neocord without doing doing cords without something else. That really worries me. If we're trying to replicate surgical, results, it really scares me to try to do something that's not as good. I realize that we have to get these devices so that we could put the two together. I understand that, but it really, it worries me that we're trying to do part of the surgical procedure and not the whole.
So I have done some neocords. In fact, I'm actually the national PI for the Harpoon trial coming up soon.
Right, yeah.
And for neocord, the patients were excluded if they had a dilated annulus.
Yeah.
Right.
And what it did show in some of the European data, because we don't have great data here in the US yet, it did show that there was some annular reduction, especially in Harpoon, that you did have some annular reduction over time, maybe as the ventricle remodels. But you're right, though, the patients get screened out if they have a dilated annulus.
Right.
It'll be interesting to see.
So maybe I would challenge what Molly said a little bit, Molly, just for the sake of discussion,
Right.
and say that if we look at mitral clip and we look at the edge-to-edge data from Alfieri and Maizano, okay, we shouldn't be doing edge-to-edge without an annuloplasty either, because the recurrence rate of edge-to-edge is significantly high if we don't add annuloplasty. Unfortunately, I think while we all agree with you, we're limited by technology. One of my concerns is,
can I just say though that that data has always been tossed around, but the hard part about that is the patients who couldn't get an annuloplasty, because I think every surgeon would want to do an annuloplasty, but the patients who couldn't get an annuloplasty also were the ones more likely to have recurrent MR. So it's hard for me to understand that as an interventionist. Maybe Vino, I would love to hear your perspective on that. I firmly believe that an annuloplasty is needed, but that data about Alfieri with and without a ring has always been difficult for me to interpret.
So I will tell you, Alfieri abandoned Alfieri by itself without the ring. And the amount of recurrence that occurred was staggeringly high if he just did the Alfieri. But if you did an Alfieri, I'm talking about all surgical, I'm not talking about transcatheter here. Alfieri by itself didn't have the best results. Alfieri with the ring had great results.
Yeah.
And so in the surgical arm, Alfieri did switch over to adding a ring to it. And that's so Molly has a point. However, I actually today don't think we have great data on either side of the story to predict one or the other. That I think we need to do a better job of getting core lab adjudicated data, not single institution. Oh yeah, we saw the patient on our own echo lab. I really think we need to move away from that, Paul. Wouldn't you agree?
Yeah. No, I completely agree. And I think that's the hard part, because I think every mitral patient deserves a ring.
Yeah.
Right. And
Right.
if they don't get one, then I'm like, okay, well, why didn't you get one? Was a calcification, something you couldn't do? And then that makes me wonder about the pathology that we're.
But maybe we see them differently. I would tell you that we're the bottom feeders, right, in the ocean. So we're seeing the patient so late in the game that I've never seen a mitral regurgitation without a dilated annulus personally.
Yeah.
Right. So if we maybe get it a little bit earlier, maybe Molly, to your point, maybe we could get away with not doing something like a ring. But when it comes to us as a group here, we're seeing them too far down the road, in my opinion.
Gotcha. Yeah, that's true.
And I would say, I think,
Herms?
Yeah, I think we're all enamored with the idea of the annuloplasty, but the technology's got to be there that we can do it in a reasonable time frame.
Yeah,
hopefully we'll get there.
And so, as you mentioned, also, Ashish, the Cardioband mitral program has been abandoned right now. Brian Wisnat, we're going to be the national PIs of that. It's now going to Cardioband tricuspid only pathways being looked at, not the mitral. So right now, guys, and Molly, all we have really going for us is the millipede. As far as annuloplasty, that's actually maybe hitting clinical trials, which, as everybody knows, is by Boston.
Yeah, as someone who's done many Cardiobands, one of the challenges is the time it took, right, and the learning curve associated with it. And I think that was the biggest challenge when Cardioband got commercialized in Europe. People were used to they had forgotten about the 4-hour mitral clip procedures that we had done years ago, and mitral clips had become so standardized. So to now sit there for 4 hours trying to put in 16 anchors was just a big challenge, and many people were not prepared to spend the time and get up the learning curve.
So Azim, do we blame this on you? You should have done it in about a half an hour. Then it would be great.
Hey, listen, I did one of the 5 cases with Cardioband, so I was brave enough to do that, or stupid enough. I'm not sure.
So Azim, should we go? Absolutely. Any other questions or comments on this? Or Azim, should we go to the next talk?
Let's go to the next one.
Yeah.
I think we move a little bit away from devices to talk about imaging. We can't talk about mitral devices without talking about imaging. And Richard is going to talk to us about, I don't understand the title, conventional and unconventional imaging for success. For me, it's always unconventional. So let's see what Richard can teach us.
Hello, my name is Richard Bay, and I'm the director of the Echo Lab at the Minneapolis Heart Institute. My talk is Conventional and Unconventional Imaging for Success with Transcatheter Repair. Here's my disclosure slide. The goals of intraoperative echocardiography for MitraClip are to define or confirm the pathology, guide transeptal access, guide the intermediate procedural steps, visualize clip location and positioning prior to deployment, visualize the grasp, and to assess the results. For MitraClip, the 3 main TE views are the 3D en face view, which gives us an overall layout of the valve anatomy, the long axis view, which will most often be the grasping view, and the commissure view, which tells us where the regurgitation is located, medial to lateral, along the commissure, and how broad the regurgitation is. The A2P2 location is the ideal location to treat, given the relative absence of cords in this region. When imaging the commissural view, be sure to slowly rotate the probe back and forth to ensure you are capturing the broadest extent of the regurgitation. In the upper left image, it looks like the MR is originating from the lateral A2P2 region, but with slight probe manipulation, we can see the regurgitation is actually broader across A2P2. Medial and lateral commissural pathology can be approached, but may be more challenging with some risk of getting the clip caught in the cords. The X-plane view with the commissural view on the left and the grasping view on the right is very helpful during this procedure. When the cursor is moved medial or laterally on the left, the corresponding grasping view at that location is displayed on the right. Here we see a P2 flail. Color is added showing the regurgitation is in the A2P2 region, and the grasping view we see the regurgitation is anteriorly directed. The 3D en face view is also helpful for an overall view of the anatomy. The width of the flail segment can be assessed from the commissural view or from a 3D image if the upper part of the zoom box is just above the mitral leaflets in systole. Ideally, this will be less than 15 millimeters. The flail gap can be assessed in the grasping view and should ideally be less than 10 millimeters, although these are all relative guidelines. The XT varieties of the clip have frictional elements extending 9 millimeters from the end of the clip arm, and thus the leaflet length to use the XTR or XTW clip should be at least 9 millimeters to engage all of the frictional elements. The NTR or NTW can be used for shorter leaflets, which are at least 6 millimeters long. Large flail gaps, calcification of the leaflet tips at the target grasp area, severe mitral annular calcification, or small posterior leaflets are problematic anatomical features which need to be carefully considered before proceeding. A baseline gradient is important to obtain and generally should be 4 millimeters of mercury or less. The mitral valve area can also be estimated from this by the pressure half-time method, but I prefer to directly planimeter the mitral valve area from the 3D images looking up from the LV, with the lower part of the 3D zoom box positioned just below the leaflet tips and diastole. The valve area should be ideally greater than 4 centimeters square, as smaller areas will likely result in some degree of mitral stenosis. I also like to look at the atrial septal height on the screening TEE. If this is not easily measured on the 4-chamber view, it can generally be better assessed in the reverse 4-chamber view as demonstrated here. Sometimes if the RA is not enlarged, the maximal atrial septal height may be borderline. The height preferably should be about 4.5 centimeters. I also like to visualize the fossa with 3D looking from the lateral LA perspective. Sometimes the fossa can be located low down close to the valve or located more anterior or posterior. This view gives us an idea of where the ideal transeptal target might be relative to the fossa. On to procedural imaging. The transeptal puncture location is key. A suboptimal location, for example too low or too anterior, can make the procedure more difficult to perform and may require multiple corrective maneuvers to fix. A good transeptal location sets you up for success. We assess the tenting of the needle in the bicable view, which tells us the superior-inferior location, which does not equal height, then the short axis view, which indicates anterior-posterior positioning. We then move to the four-chamber view to assess height. Ideally, you will be able to see the tenting of the atrial septum, lateral LA free wall, and mitral valve all in the same view as on the right. Sometimes you can't get the LVOT or aortic valve out of the way in the four-chamber view, making measurement difficult as in the upper left. Also keep in mind that the plane of the atrial septum is not always the same as the ventricular septum, as can be seen in the lower left CT image, and this may affect your geometric assumptions. When you can't get the LVOT out of the way in the four-chamber view, again, I'll rotate the probe to approximately 140 to 180 degrees to get a reverse four-chamber view. 2D imaging is used to guide the transeptal puncture location, but to get the best confirmation of where exactly the needle crossed, I like to switch to a 3D view of the atrial septum viewed from the lateral LA perspective right after crossing. Here we can see we crossed at the highest point of the fossa. This is another example showing we cross very posterior and high on the fossa. When we rotate the image to the surgeon's view, we like to see the catheter cross close to the medial commissure or posterior to it. Here we can see the catheter is very anterior and results in an aorta hugger trajectory, which may need to be corrected. As the clip is advanced into the LA, the echocardiographer must continuously visualize the tip of the clip to prevent perforating the free wall of the LA or getting stuck on the Coumadin ridge. The clip is then brought down towards the valve where the pathology is located. Clip arm alignment is best done in the 3D on FOSS view to achieve perpendicularity of the clip arms to the commissure at the point of interest. We like to advance the clip into the LV under X-plane imaging. This way we can simultaneously assess whether the clip is diving medially or laterally, or if there is a significant anterior-posterior bias. The clip is then opened in the LV, and we can use 3D again to see if the clip rotated as it was advanced into the LV. Sometimes the 3D gain needs to be reduced to make the leaflets disappear to see the clip arm orientation better. We then go to the grasping view and zoom up to give us the best visualization of the leaflets and clip arms. The clip is brought back slowly to the valve with fine catheter adjustments to position it to optimally grasp both leaflets. Watch out for leaflet curling, which will prevent good leaflet capture. Once both leaflets are seen resting deep into the clip arms, the grippers can be dropped. We like to see the grippers lifting, which is additional confirmation that there is good amount of leaflet between the grippers and the clip arms. Pains should be taken to optimize the imaging of the grasp, with good visualization of both clip arms and the leaflet tips. Here's another example of a grasp. If you see leaflet lifting above the clip arms in systole, this should give you pause to consider whether you have enough leaflet inserted into the clip. When you have a relatively short posterior leaflet, you also want to pay attention to see if any of that leaflet slides out of the clip during the grasp. Here you can see the posterior clip arm is wedged under the posterior leaflet to the annulus, and the posterior leaflet does not slide out during the grasp. Leaflet insertion is assessed in the grasping view and four-chamber view, but don't forget to assess it in the commissural view as well. If the leaflets are inserted deep into the arms, you should see the leaflets intersect the middle of the clip in this view like a cross. After leaflet insertion assessment, we will close the clip completely under color in the commissural view to get a real-time visualization of any further reduction of the MR. Color flow can then be assessed in other views. 3D can confirm the presence of a good tissue bridge and if the clip captured the flail segment target, for instance. The gradient is reassessed, and don't forget to check if there's any change to the pulmonary venous flow, for example, elimination of systolic flow reversals. Here's a brief case highlighting some unconventional views. Here we have a case of mitral regurgitation and hypertrophic cardiomyopathy. The LVO2 gradient is demonstrated from deep transgastric views. This is the resting mitral gradient. Here we see late systolic flow reversal in the right upper pulmonary vein. Here's a 3D view of the valve from the LV side. You can see the systolic anterior motion of the mitral valve with septal contact. This is an unconventional view. Here we see the 3D view of the atrial septum from the LA side. You can see the fossa is low towards the mitral annulus, and so we needed to cross the thicker part of the atrial septum above the fossa. Here you can see the transeptal puncture through the thicker part of the septum. The clip is advanced into the LV to capture the anterior leaflet where there is systolic anterior motion. The clip is deployed with trivial residual mitral regurgitation. The 3D view of the mitral valve from the LV side shows the systolic